This lecture will include the chapter that is concerning our special senses, and it is the last chapter that is part of the nervous system that ends our content within Anatomy and Physiology 1. So let's go ahead and jump right in here and see what we need to learn from this last set of information on the nervous system. So we've already had our introduction to neurons and glial cells, and we understand that the nervous system is composed of very special types of cells that have very special functions in communication, in sensing and responding to environmental changes, and then sending signals on to sometimes other nerve cells, but also to muscles and endocrine organs. So in this particular information chapter, we're going to be looking at our special senses. And we understand that not all neurons are created equal as far as the anatomy. So they are ones that have very special functions to sense pressure, some that are going to have functions that are pressure are mechanoreceptors, some that are going to sense chemical changes like oxygen level changes, CO2 level changes, pH, those types of changes, thermoreceptors that are going to detect temperature changes, and nociceptors that detect pain. So depending on what they're designed to do, they're going to have very specialized functions. So we understand that they wouldn't all look alike. It wouldn't even make sense to think that their anatomy was the same when their functions are different. Remember, anatomy and structure always dictates function. Some are unencapsulated, some are encapsulated. So again, there are many different types of nerves that we understand that have very specialized functions. When we think of pain, we don't think of that as a bad, well, we usually think of it as a bad thing, but actually it's very protective. We need to have pain so that we understand that something is injured, and when it's injured, we are going to take care of it, lay off of it, take care of it. It's going to alert us that it could be an injury that if we don't give it immediate attention, then it could be life-threatening. So when we think about pain, we do know that sometimes pain is a sharp kind of rapid pain that when we consider it sharp, and then there's slow pain that we associate it with unmyelinated fibers. And there are pain receptors everywhere in the body except for the brain. And there's even evidence that a couple of thousand years ago or more that people were doing brain surgery. And so we understand that that has been something that's been around for a long time. There are chemicals that stimulate pain. These chemicals are referred to as neurotransmitters and also sometimes hormone classes. That some of the ones that we associate are bradykinins, histamines, and prostaglandins. Again, these are going to be produced in injured tissues that release these so that you are aware of pain. Now, as far as pain goes, typically your brain gets it correct. So if you hurt your hand, that's what's actually hurting. But sometimes there is something that we know that happens that's called referred pain. And really, the brain is misinterpreting this pain. Luckily, we actually kind of know the common misinterpreted pain. So in medicine, we understand that if someone is coming in with sometimes jaw pain or left arm or left hand, we know it could actually be related to heart injury. So I think everyone has heard that before. If someone's experiencing left arm or left hand pain, it could actually indicate an impending heart attack. And the same thing goes with jaw and neck with the heart. You can see some of these other referred pain situations that are very common in medicine. The gallbladder attacks when people are producing gallstones that are blocking the bile ducts. They can have gallbladder attacks. Those can actually present themselves not near where the gallbladder is actually located, which is just inferior to the liver in this region of the upper right quadrant, it can actually end up causing pain between the shoulder blades and the back of the neck. So again, there are just a few referred pains that we understand in medicine, and we understand to look for those. And when we see patients who are experiencing pain in these regions, we know that we may be wanting to look in another direction because of this misinterpreted pain or referred pain. Now, as far as the intensity of pain, I know that many times in emergency rooms and all of the cubicles, they'll have a little chart that patients can look at to evaluate their pain on a scale of 0 to 10. And they show different examples of that. But it's a really difficult thing to measure. So when we think about pain as a sign of disease, something that is measurable, even though we have that scale, I would argue that it's really not measurable, because some people's 7 on that scale may be another person's 2. So it truly is individual. You guys have heard of a high threshold for pain or a low threshold for pain that the patient has. And some patients come in and tell you, I have a really high threshold for pain, and this is unbearable. I'm at a 10. Well, honestly, if someone's at an 8, 9, or 10, they're not listening to your questions, much less answering you about where they are on the scale. They're not able to hear you. They're not talking to you. So you're using other things like blood pressure and their vital signs to help you to evaluate their intensity of pain. We have natural opioids that we have already discussed, and when we're looking at neurotransmitters, endorphins were ones that I had talked to you about. They're also enkephalins and dynorphins. So we have natural endogenous opioids that are incredibly effective in helping to deal with pain. And this is why you can have sometimes, again, in your emergency rooms, people come in with horrific injuries and they don't even know it. Because their body has secreted those. And so for this short period of time, they truly are working to alleviate that pain. Now, another sense is taste. When we think about taste, this is a superior view of your tongue. Okay, so a superior view of looking at the tongue. This is the front tip of the tongue. This is at the back of the throat. So when we think about the sense of taste, there are 5 actual different types of taste buds that are responding to 5 specific types of taste. Those are going to be, those 5 primary sensations are going to be here, and I would want you to know them. They are salty, sweet, sour, bitter, and the 5th one, which is relatively new, is called umami. I think salty, sweet, sour, and bitter, sort of, you would understand those, you know those. Umami has been described as beef bouillon-y, or beefy, or meaty, meaty. So I don't know. So beef bouillon to me just is salty, so I don't know. But anyway, this is a distinct 5th one. Now, when we think about how they are, what they would look like on a histology slide, a cross-section of tissues, and you can see the cells here on the superior region of the tongue, and you can see this little bulb, this little taste bud here. When we think about these 5 particular types of taste buds, they're spread throughout the tongue, but the sweet ones are concentrated on the tip of the tongue. You can think about how you lick an ice cream cone with the tip of that tongue. So sweet on the tip predominantly, but they're kind of all spread out. Salty on the sides, and sour and bitter at the back of the tongue. And maybe you can think about if you've ever had anything really bitter, it's generated from the back of that tongue area. So we understand that for things to be tasted, these molecules must be dissolved in saliva. So it's very important that the salivary glands, which we really haven't even labeled yet, but you have sublingual salivary pair beneath your tongue. you have submandibular pair beneath your mandible, and you have the parotid salivary glands on either side of, just in front of, anterior to your ears. So you have the parotid, the sublingual, and the submandibular salivary glands that are secreting about 1.5 liters of saliva a day. And as you all know, that if you smell something that smells good, or if you even sometimes think about food and you're hungry, you start to salivate, do you not? Saliva has a lot of different functions, but one of the functions of saliva, this just is one, is that it's emulsifying the food so that the taste buds can actually be innervated, and you can have these 5 senses of taste. Now, many of you are thinking, maybe you're thinking, but what about like taste like lemon and orange and those, that actually, there's really only 5 senses of taste. What you're thinking when you think about all these other flavors is actually smell and taste in combination. So maybe you will also keep in mind that if you've ever had, your nose was completely blocked and you knew that you had lost your sense of smell, maybe from a cold or sinus infection or allergies, and for smell, you also have your nose, inside of your nose needs to be really wet for you to be able to smell. So the inside of your nose areas are very, very moist. We'll see that in a second. But if you've taken something to maybe dry out or decongest, you've lost your sense of taste as well. So anyway, they are kind of combined. But when thinking about taste, there really are only 5 primary sensations. And we have looked at those cranial nerves. We understand that there are several cranial nerves that innervate the tongue. And that means that those cranial nerves, which have a direct link to your brain, your central nervous system, are all innervating that tongue. The tongue has a lot of functions. Manipulating food, this is just one of them as far as this special senses of taste, but we know your tongue manipulates food. It helps for you to speak. There's lots of different functions for that. Now, smell, which I've already sort of begun. When we think, this is a mid-sagittal section of the face. So your nose, the tip of your nose here, the nares, where air moves in. As air moves in each side, we are bilateral, right? So as air moves in each side in this sort of small area, it gets dispersed. And it gets dispersed through actually a pretty large area that it's going to move through. And these regions are actually referred to as the conchi, and you can see that there are raised areas of tissue and then almost like depressions of tissue here. But what this tissue is very vascular. So there are lots of blood supply here, and that blood is bringing warmth and it's bringing moisture to these tissues. So the inside of your nose needs to be very, very moist, very warm, because it's warming air, which expands the air. It's humidifying the air, which again helps when the air gets to the lower regions of the lungs. It helps for the disbursement of gases between the alveoli and the blood capillaries. So warming the air, humidifying, and warming and humidifying are both important for respiration. But humidifying and keeping it very moist is also important for smell. So again, for something for you to be able to smell something, it has to be volatile. It has to have been wet. In other words, there are some people who can distinguish as many as 10,000 different odors. I don't know how long it took for them to test a person on that, but some are very, very sensitive to smells. So, and some people are less sensitive to smell. The cranial nerve is the olfactory nerve that provides smell for us, and you can see that. You can see just an illustration of it here. The olfactory nerve, the pair of olfactory nerves, that innervate for smell are moving predominantly to the temporal region of the brain. So these are the nerve endings that are going to be innervated, where action potentials are created, but where you interpret smell is actually your brain. Just like where you interpret taste is actually your brain as well. So these special senses, yes, we're going to look at some of these nerves that are involved with this, but remember, it's always your brain that is the great interpreter, right? Which is part of the central nervous system. So, so let's see if there's anything else I wanted to tell you here. Again, this idea that as air is flowing, it's going to innervate these olfactory cells so that action potentials are created, and then that is sent, again, the volatile just means to be wet, it has to be wet, sent to the temporal lobe. There is this next picture shows you how close these olfactory nerves are actually to your amygdala and the hypothalamus. And the amygdala, we knew, if we looked at an inferior view of the brain, we see the olfactory nerve crosses here. The olfactory nerve is very, very close to the amygdala, which is the emotional response. This is why, and also the hippocampus, this is why odors sometimes can take you back to a memory quick and an emotion, because memory, hippocampus, and emotion, the amygdala, quicker than a vision can, than seeing something can. A smell can really sometimes take you right back to a particular event and or an emotion. So this is why that is. Now, moving on, like I'm sort of moving through here, but giving you the basics of this, we're going to take a look at sound. So hearing, right? And when we think about sound, we're going to obviously dissect we're going to dissect the ear. And when we think about this ear, I'm seeing if I have a bigger picture, I do. When we think about the anatomy, I'm just going to look at the anatomy of the whole ear here, not just the middle ear, because the picture's larger. But when we look at the anatomy of our ear, what we see externally is this auricle, the shell. The auricle is really the entire external area here. It's the shell of the ear. And it is a perfect design to capture sound waves as they hit this area, capture them and funnel them into this outer ear canal. So when we think about the ear, we are hearing, we really do break this into three regions: the outer ear, the middle ear, and the inner ear. So the outer ear includes the auricle, the auditory canal, all the way to the external surface of the tympanic membrane, which is what people call the eardrum. Now, from the inside of that membrane here to what we call this little oval window and round window area, this is the middle ear. The middle ear includes three tiny bones: the malleus, the incus, and the stapes. Ossicle means bone. These are three tiny bones that are articulating with each other. They're separate, but they are articulating with each other. And if you notice, the malleus is connected to the inner layer of the tympanic membrane. So if the membrane is vibrating, the malleus will be moving. And if the malleus is vibrating, it's going to cause movement of the incus. And if the incus is moving, it's going to hit the stapes. And if the stapes is pressing against this oval window, the inner ear will be affected. So the inner ear includes the region of the vestibular apparatus that has these semicircular ducts, vestibular nerve, which is for balance, and the cochlear region of the inner ear, which is innervated for hearing, the cochlear nerve. So all regions of the ear must be functioning for you to be able to hear. If for some reason the auditory canal became blocked, sound waves couldn't move through. If the tympanic membrane for some reason ruptured or hardened, it wouldn't be able to vibrate. If the middle ear, instead of being filled with air, as it should be filled with air, if for some reason it was filled with fluid, that would affect the vibration of the membrane, and it would potentially affect the articulations, the joints between these three tiny bones. If there was damage to the cochlear region, then any area here that would have damage could potentially affect your hearing. It may be temporary, or it could end up being a permanent type of damage. All regions of the ear have to stay healthy for you to be able to hear. So what I'd like to do is actually show you a mechanical version of this ear, and the mechanical description, I think, makes this easier to understand what's going on. I want you to think about this mechanical version and relate it, outer ear, middle ear, inner ear, to this picture that you just saw. And let's look at the mechanical illustration of this. The auricle of the ear here, which would be the auricle, would capture sound waves. So as sound was created with compressed molecules, actually moving away from where the sound was generated, moving through the air, these compressed molecules in the air, as they were captured by the auricle and sent through the auditory canal, they are funneled in to hit the membrane, the eardrum. And as the waves hit the eardrum, it causes it to vibrate. So as they hit, it presses in, and then there's a slight release, and then the next wave hits, and it vibrates. As it vibrates, the malleus, which you see my mouse is on, the malleus will move, which in turn moves the incus, which in turn moves the stapes. And as the stapes presses on that little oval window, the inner ear is now going to be getting its signal, and the cochlea will be involved, sending a signal through the cochlear nerve to the temporal membrane of the brain that interprets this as sound. Any damage in any of these regions could lead to hearing loss, which hopefully wouldn't be permanent. But there are many, many causes of hearing loss. Some of them are congenital, so it's from birth, and some of them are due to injury or pathologies like recurring infections. I want you to think about this outer ear, and I'll go back to the actual picture of an ear. This outer ear has many things in place that are protective. So the way that the tilt of this canal is, it allows for drainage of water. You know, we don't just get water in our ears when we swim. We get water in our ears when we are washing our face and splashing water, or taking a shower, or, you know, submerging if you're in a bath, a big enough bathtub, whatever. You can get water in your ear. And this canal, the slant on this canal is actually helping the water to drain, because we don't bathe or shower or swim in sterile water. We're not in a sterile environment. We're not meant to be. So the water needs to get out. We have glands called ceruminous glands, which you all have learned about already, that are found here that secrete earwax. Earwax waterproofs this canal. It also keeps pests out of this canal so that they don't crawl up in here and hurt your tympanic membrane, your eardrum. There are little hairs here that actually trap pollutants and other things that could be there. And the earwax drains, and it's self-cleaning this auditory canal is. It's very important. You've heard that you should never put anything in. You shouldn't use Q-tips. You should not put anything in this auditory canal, because it could be that there are a lot of pain receptors here, so it would hurt, and they're nociceptors, and it could be that you would rupture your eardrum, or you would pack in the earwax, and packing the earwax down could potentially block the sound waves that are coming in, so that wouldn't be good either. The outer ear can get infected. This is called external otitis. External otitis. You would want to write that down. External otitis, and I will just write this. I'll just use this to write this so that you all know. External otitis is usually caused from a bacterium called Pseudomonas aeruginosa. This is a microbe. This is a bacterium that is in all water sources. It's in your hot water lines at home. It's in hot water lines in hospitals. It's everywhere in the environment. It's in lakes and waters and rivers, and it's there. It's in the soils. Pseudomonas aeruginosa, though, likes warm water, likes warm temperatures. And if you've ever gotten in a hot tub and you've seen that, it's almost like it's like a fluorescent sheen on the top of the water. It's from that bacterium. It means there's enough of that bacterium present that you're actually macroscopically seeing that with your eyes, that fluorescent sheen. And it's part of our, it's part of our world. But if that gets trapped in your external canal, this is what we end up knowing causes what we call swimmer's ear. So swimmer's ear is external otitis that can be treated with antibiotics that will target Pseudomonas aeruginosa. Now, let's look at the middle ear. The middle ear, it's so important that the middle ear cavity, this cavity where my mouse is right here, be filled with air, that the middle ear actually has a drain tube. This drain tube is called the eustachian tube. Most of the time, you all have heard of this as the eustachian tube, but it's called the auditory tube on this little thing. Anyway, this actually drains into the nasopharynx, which is the back of the throat, right behind the nose. This tube, again, has a fairly nice slant on it so that gravity helps to keep this drained. But in young kids, this slant is not so slanted. It's more horizontal. And this is why younger people have more otitis media. Itis means inflammation of. Otitis media of the middle ear, because this tube doesn't have as nice of a slant. Also, because young kids have more cold viruses than adults do. By the time you're an adult, you've already encountered many cold viruses, so you have about 1/3 of the cold viruses that a young child will have. Once you've had one, you don't have them again, but there are hundreds of viruses that cause what we call the common cold. This is why we have never had a cure for the common cold, because there are literally hundreds of viruses that cause the common cold. Now, you get over it. It's a common cold is going to last about a week, or you can treat it in the last about 7 days. So I hope you heard that there. There's really nothing you do. You just really get over it yourself. It doesn't mean you shouldn't treat yourself with like extra fluids and extra rest and those types of things. You would want to do that. But there's really no cure for the common cold. But it also is something that most people get over. Now, it could be, though, with that extra fluid that happens with a cold, the extra fluids that are going to accumulate in this region, especially in a child, it could be that fluid will become trapped in this middle ear. And if that's the case, it's going to push out this membrane. That fluid causes that membrane to be pressed out. So even though sound is moving through the auditory canal, being captured by the shell, the auricle of the ear, and moving through the auditory canal, the membrane has fluid behind it. So it really can't vibrate. So sometimes when people have recurring or keep otitis media, it can affect their hearing. In young children, if this is the case for long, it can affect their speech because they're not hearing, so they don't know how to mimic the sounds. The reason that we mimic sounds and learn speech is that we really are copying what we hear. So if a child goes for really long periods of time with otitis media, there's real risk that they're going to be developmentally delayed in their language skills. So this is why, too, that sometimes in children, rarely but occasionally in adults, they will put a tube in the eardrum. So having tubes put in the ears, they actually take a little tiny, and it is tiny, a little hollow tube, and they actually puncture through the eardrum. So they're damaging it permanently and scarring it when they do that. But they make that evaluation that the person has had so many middle ear infections and fluid has stayed around so long in there, they're going to give it another way to drain. So not only is the auditory tube hopefully going to start taking, most of the drain, but they put a little hollow tube into the puncture through the membrane so that that fluid can also drain this way out. Now, most ENTs, ear, nose, and throat docs that do this procedure, they hope that the tube stays in at least 6 months and then they're happy. Sometimes the tubes fall out before the child gets out of the parking lot after having it done. Sometimes they stay in too long, and they don't want them to stay in too long either. They hope for around 6 months that they stay in until the drainage can happen, and then hopefully also as the child ages and the head becomes more adult size by around 6 to 8 years, then they've got a nicer slant on this eustachian tube. Again, eustachian, E-U-S-T-A-C-I-A-N. Eustachian tube is the same as the auditory tube. Now, because this tube is connected to the back of the throat, right behind the ear, behind the nose, so you have the nasopharynx, oropharynx behind the mouth, and laryngopharynx. Pharynx just means throat. Because it is a connection there, we also have to realize if viruses or whatever can get in the eyes drain to the nose, and you know that because when you cry, your nose runs, doesn't it? But there's also this connection to the back of the throat. So sometimes if somebody has eye infections, you want to check their eardrums because you want to see if that infection hasn't maybe migrated and causing an otitis media. You'll know because the eardrum is going to be irritated and looking like it's pressed out. Also, bulging. Also, if someone has a sore throat, pharyngitis means sore throat, inflammation of the throat. You want to check their eyes and you want to check their ears because, again, there is this connection. And you know that because if you hold your nose and close your mouth and put pressure in this area, your ears pop. And the reason is because of this eustachian tube. Now, the inner ear, hopefully nothing has damaged that, but this cochlear region is filled with nerves that if they do become damaged, they can't send signals to the cochlear nerve to the temporal lobe of the brain, and typically that is a permanent type of hearing loss. If they're damaged to any of these areas, you have a couple of deeper insights in this chapter, and you would want to look at those before you actually take the test on this section. But I hope this has given you some understanding for hearing. It is very important to note as well, this is showing you the cochlear region. If there was a dissection of this cochlea, if we did a dissection and then we blew up this one little area here, we would see these nerve endings. This is called the organ of corti, which is really the organ of hearing. As these nerves, they're calling them hair because they really do look, they're cilia, and cilia just means hair. The hair-like endings of the nerves, if they become damaged, then they don't regenerate. So progressive hearing loss can happen if there's progressive damage to these areas. And a thing to think about with that is sound. When we think about loudness, that's measured in decibels, and you can see frequency as well. But when we think about loudness in decibels, speech, it falls within 40 to about 80 decibels here. So that's usually around what speech is in. And then we know that, let me see if I can show you this in a different way. So we know that music, we like music a little bit louder. And we know that there's other sounds. Some people like music really loud. So there are other sounds that are really loud, like gunshots or cars backfiring, or, whatever you can think of that's like really loud, fireworks, that type of thing. But what's important to note is that sounds that actually are above 90 decibels, 90, right here, 90, end up causing permanent hearing loss. So exposure to those types of sounds that wouldn't even be wouldn't even be making you want to close your ears or cover your ears, can lead to permanent damage. And this is I think that's a very important slide to be looking at, really. So let's see if I can end. Oh gosh, whenever I do this, I never know how to get out of it. There you go. So this is just something to consider. Earbuds that a lot of people are using now, even children are using these. Hopefully they're being very closely monitored though, because sometimes they're put on to protect against sounds that can be a lot, but you should be careful when you're listening to music or whatever about how loud it is, because again, it's actually thought that we really do live in a very noise polluted world now with music and just the things that we're constantly being exposed to that aren't considered to be natural sounds. That a ear, nose, and throat doctor a long time ago actually told me when the earbuds first started coming out and people were listening to music that way, that their jobs were assured, because people by the time they were 40 were going to have severe hearing loss, permanent hearing loss. So anyway, I'm sure they didn't want that to be the case. It just is the case. So, all right, so that is hearing. And again, you can see electron micrographs. This is a scanning electron micrograph of those cochlear hair cells. And as that oval window from the stapes is pressing in, then it generates almost wave-like actions that end up affecting these nerve endings. And as those nerve endings get bent, action potentials are created where sodium pours in, potassium pours out, voltage change happens along that nerve, and that gets sent to the temporal lobe. Now, we do know that protection actually occurs when if a natural sound is building, like thunder builds to a clap of thunder. If you all know, natural sounds tend to build. So when that happens, the stapes, a muscle, the stapedius muscle, will tighten down to protect that cochlear nerve. The unfortunate thing is that unnatural sounds that are loud, like blaring a radio or whatever. Do people listen to the radio anymore? Whatever. Or backfiring of cars or that kind of thing. Then the stapedius and some of these muscles that tend to protect in natural sounds don't have time to do it. And that's why the nerves can become damaged. Equilibrium. Okay, so hearing, let's go back to this. Again, the temporal region. of the temporal region of the brain is where sound is interpreted. You all have all heard of cochlear implants too. So you know that sometimes people who have had nerve damage to the cochlear nerve can have cochlear implants. They can actually, after sometimes never hearing or not hearing for many years, can now hear again. So that's an amazing thing. Equilibrium is in this is part of the inner ear. Remember, the inner ear looks kind of like a snail, doesn't it? Well, this is the cochlea, and this is the vestibular apparatus that has these semicircular ducts filled with endolymph, which is a type of fluid. This fluid has these tiny microscopic bony crystals called otoliths. These otoliths are floating in this fluid, and as a person is, moving, most of us can't do like this gymnast can do, but turning cartwheels or spinning or moving, then these otoliths are moving across these nerve endings, again innervating these hair fibers of the nerve cells of the vestibular nerve, so that you interpret that and can maintain balance and equilibrium. When someone has vertigo is when these otoliths actually get jammed into these hair-like nerve endings, and that makes the person feel like they're moving when they're not moving, and it can really cause a lot of problems. So vertigo can. Okay. So now sight. So we're going to take a look at vision and learn a little bit about how vision how it works, that we can actually see. So the visible light that the eye can actually be innervated by is measurable on a visible light spectrum scale, and we can interpret light waves that range between about 400 nanometers to approximately 700 plus nanometers. So what this light wave does in these very special receptor cells that we have in the back of our eye is that it can cause a photochemical reaction there. And so when we think about that, it means that light, as it's hitting the earth and coming into our eyes, we have to have these structures that are perfectly clear. Or they should be perfectly clear so that light can actually enter. So when we're looking at a person's eye from an anterior aspect, this most superficial structure is actually referred to as the cornea. I think it's better to look at this from a lateral view. But anyway, the cornea is a superficial thick coat of the eye that is perfectly clear. And it's definitely going to be better to look at it from here. So as we look at this, as light would come in, this illustration has the lid closed, but as light would come in, it would hit this cornea that is curved. Light waves would move through that front part of the eye, the anterior chamber of the eye, moving through a hole called the pupil, and continuing to move, because if there's anything that would block the light, it would be refracted back. So all of these structures have to be clear. So the cornea, the anterior chambers filled with water called aqueous humor. Anyway, it's clear, goes through this hole called the pupil, and then a structure called the lens, which is also clear. And then the back chamber of the eye, which is filled with a jelly-like, almost like a raw egg white, which is clear. And light waves can move all the way to the back of the eye. Now, when we think about the eye, we're going to take a look at that eye in just a few minutes. But when we think of that, we're going to think about the normal anatomy, and that every one of these structures need to be healthy. If there was any sort of damage to any of these areas, it could affect your sight, and all of them have to be clear in life. Now, again, just looking at this external anatomy, the eyes are so protected because sight is something that if someone does not have sight, it is one of our first senses for survival. Sight and hearing, obviously, for survival. We are a social species, so that when we do have individuals in our tribes or whatever, we tend to take care of the ones that don't have sight. But if they weren't taken care of, they would not survive. So sight is vital to survival, really. And so the eye is incredibly protected. There are eyebrows that actually are going to capture and any sort of debris or keep things from actually entering into the eye. You have the lid that's constantly closing and moistening the eye, encouraging the lacrimal glands, which are found here in this upper lid region. The lacrimal glands are producing constantly tears. These tears are constantly, every time we blink, are moving across the eye, washing the eye out. And any excess would be draining through this lacrimal duct into the nose. Now, typically it's not enough of a drainage that your nose is running, but it's constantly staying moist from that reason and protecting. Tears have a lot of antimicrobial properties, and they have antibodies that are keeping the eye clean and essentially sterile, believe it or not. Most of the time, if someone has a culture done on the eye, there really won't be anything growing. So, if it's doing its job. Now, if the tears are doing their jobs, and if the lids, and if the eyelashes, and if the eyebrows, and the person's taking care of their eyes, then it's very, very well protected. There's also an inner membrane. If we were to pull our lower lids down or look in the upper, there is a membrane that's very vascular. You can see the blood vessels even with your unaided eye. Very vascular, that actually extends over the white of the eye. So this membrane is called the conjunctiva. And this conjunctival membrane, again, is another layer of protection, but also nourishment for the eye, because it is very vascular. If you've ever seen someone with bloodshot eyes, it means that those blood capillaries have dilated enough that you can actually see them with your naked eye. You can see those blood capillaries now. Blood capillaries are typically microscopic, but if for some reason through infection or inflammation or injury, they have dilated and more blood's being brought to the site, then you actually see them. There are sometimes the conjunctiva is actually inflamed. So if that conjunctiva is inflamed, we call this conjunctivitis. There are many different causes for conjunctivitis. The most common is allergies. The next most common is viruses, and the rarest cause of conjunctivitis are bacteria. Each of them present slightly differently. Unfortunately, they're all kind of grouped in what sometimes people refer to as pink eye, which is unfortunate because sometimes, like daycares and schools, if the child has pink eye or conjunctivitis, they make the parents put them on antibiotics or say that they've been on antibiotics for a certain period of time before they let them back in. But honestly, most of the time, conjunctivitis is allergy related, so that's not contagious. And viruses can be contagious, especially direct contact. From one eye to the next, it can be contagious, but it also can be between people. So viruses, and then bacteria are the rarest cause of conjunctivitis. Bacterial conjunctivitis is going to cause a green, thick, brownish goo that actually causes the lids to swell and sometimes close completely shut. That's bacterial conjunctivitis. Allergies and viral conjunctivitis is typically going to cause itchy eyes, draining, maybe a goldeny type of discharge on the eyes, so it's not nearly the same presentation as bacterial conjunctivitis. But anyway, that's what that is. So it is richly innervated and vascular. It heals really, really quickly, typically, and it is very much protecting the eye. Again, the lacrimal glands, they're calling it the lacrimal apparatus. This lacrimal gland is going to be producing tears that are washing across. And again, you can see these lacrimal ducts that drain into the nasal area. So again, this is why if someone does have conjunctivitis and there's inflammation here of this, and then it's draining into the nose, which is draining to the back of the throat, which could connect the middle ear. If somebody has conjunctivitis, check their eardrums, check their ears. So anyway, that's tears. And when we think about innervation and moving the eyes, we saw that there were quite a few pairs of cranial nerves that move the eyes, and that sort of made sense to us since we do have two eyes to have to be able to see clear vision. They have to be working together. So we saw the abducens, we saw the trochlear. We looked at these when we were looking at the pairs of cranial nerves, the oculomotor nerve. So there were quite a few that actually innervate and help us with clear vision and moving the eyes. When we look at the tunics of the eyeball itself, and this is going to be the picture that I really am going to use for the rest of this talk about sight. When we talk about the layers, the tunic just means coat, and coat just would mean layer. The outermost white of the eye is called the sclera. This is the white of the eye, the outermost layer. And it is continuous with the clear cornea that has to be completely clear. If the cornea gets damaged or through infection, which can happen, gets cloudy, then it's going to affect the sight adversely, because light waves can't come through something that's not completely clear. They can't move through it. So it has to be clear, and the sclera, the white of the eye, is continuous and it's very thick with the cornea. So this is the sclera. Deep to the sclera is a choroid layer, which is a vascular layer of vessels that nourish the innermost layer, which is the retina. This innermost layer, the back of the eye, the retina, is where all of the photoreceptor cells are located that become innervated, that gets interpreted as sight. The retina. So this innermost layer is obviously holding all of your photoreceptor cells. So as light waves move through, these light waves between the 400 to 740, 750 nanometers wavelengths from peak to peak, trough to trough measured, as they move through the cornea, the front chamber is filled with water, aqueous humor, through the hole called the pupil. It's a hole. It's not really a structure. It's a hole. The pupil move through this lens, moving through the vitreous. The vitreous is painted like an orange here, but it's really clear, and it looks like raw egg white, completely clear. This vitreous humor or body is holding the retina in place. In all of the dissections I've ever done, and I've done a lot, it is the retina, the fragility, the fragileness of the retina that to me is the most amazing thing. When you think about that, it is holding all those important photoreceptors, and it is incredibly fragile. This jelly-like fluid that's clear in life it's clear. The pressure of that on the retina holds it in place, fills this posterior chamber, and holds the retina in place. If the retina ever detaches, you're completely blind in that eye. Sometimes people get warning that their retina is detaching. The warnings can be sometimes what are called floaters in the visual field. Now listen, floaters sometimes are just benign, and it has nothing to do with the retina detaching. But if someone does have what they call floaters in their visual field, they almost look like little, some people would call them amoebas, sort of floating around. It can be that just a cell has sloughed off, and as the light hits it, it causes a shadow to form on the, and so the shadow is interpreted by these photoreceptor cells. But all floaters should be checked out by an optometrist or an ophthalmologist to be sure that it's not a detaching retina. Because if the retina does detach completely, then there's no going back. You're completely blind in that eye. So, this retina, this very, very thin, fragile, innermost layer, it is protected though. Look at these thick, the sclera and the choroid, these very protected layers, the cornea in front, an anterior chamber covered by the colored part of your eye, which is the iris, the lens that can actually change shape, the jelly-like fluid, the vitreous jelly, sometimes this is called vitreous humor, vitreous jelly, vitreous body, which is that slick, clear, jelly-like fluid that's filling this posterior chamber, all protecting the retina. As those photoreceptor cells become innervated, they send microvoltage change and electrical change through, it's congregated through the optic nerve to the back of the brain, the occipital lobe, and this is where vision is interpreted. So, a lot of what I just talked to you about here was from this one slide about vision, but I do need you to know that light waves must be able to move through these transparent structures. The cornea in this order. The cornea it hits, the aqueous humor, the lens, the vitreous humor or jelly, and again, this is just a section showing you, and it has to move through to be able to hit to the back of the eye. And when we think about the back of the eye where this retina is actually found, and I've talked to you about the detached retina and how floaters can sometimes be your first indicator that a retina might be detaching. I did mention optometrist versus ophthalmologist, and just give you an idea of the difference between that. An optometrist is someone who has not gone through medical school, but all of their graduate work was in sight, related to the eye, anatomy of the eye and sight. So that's all their graduate work was just dealing with the eye. An ophthalmologist is a medical doctor that has been through medical school and then specialized in sight, the eye. So that's the difference between an optometrist and an ophthalmologist. Both of them are experts in vision and the eye, anatomy of the eye, but one can do, the ophthalmologist can do a little bit more prescribing, and then also more of procedural type things with someone than an optometrist could. So I've known some very good optometrists though, who are very good diagnosticians. But anyway, that's the difference in them. So in looking at how the cornea, light would move through the cornea, through the anterior chamber where aqueous humor is found, through the pupil, which is the opening in the iris, the colored part of the eye, through the lens, through the vitreous body, to the back of the eye. With an ophthalmoscope, we can actually see the back of the eye. So this would be what would be if someone took a light and was looking through that pupil. The back of the eye you can actually see, and I want to bring your attention to this view. This is really the only place that someone can directly examine blood vessels. You can directly examine them, and this is why sometimes optometrists or ophthalmologists can actually diagnose. Sometimes they're the ones, when they're looking at these blood vessels, can diagnose, doing an eye exam, diagnose someone with hypertension, high blood pressure, or diabetes mellitus. Diabetes mellitus ends up, especially chronic diabetes that's not controlled, can end up causing blindness, but it can, they can see changes here. They can diagnose migraines because of the change in the vascular structure. So looking at, with an ophthalmoscope, looking at this exam, they can actually look at these vessels, but also look at a region called the fovea centralis. Sometimes you'll see this, that's Latin, but sometimes you'll see this as the central fovea, which is in English, but the Latin is fovea centralis, central fovea. This area that includes the macular region of the retina, I want you to, you see where my mouse is, I want you to pay attention to this. I'm going to go back and show you this here. This is the macular region, central fovea. This is not close. It isn't, well, relationship is kind of close, but it's not that close to the optic nerve, where the optic nerve leaves the back of the eye. This area is the area that the most centrally located photoreceptors are. As light is hitting, they should be hitting mostly here. And so this macular region that includes the central fovea is the area where we have our highest visual acuity. So our center vision, where we can look across a room and we can read the title of a textbook, you know, on our bookshelf, or we can look at a picture and see the little face. It's our center view, where we have the highest visual acuity. Now we also have peripheral vision. The peripheral vision would be out here. We still have photoreceptor cells, but that's peripheral vision. Now I want you all to think about some disorders and looking at a direct anterior aspect of the retina. We are looking back at that retina, an anterior view of the retina. If there's too much pressure being put on the back of the eye, the photoreceptor cells in the retina, and that pressure can be from aqueous humor putting pressure on the front chamber, which puts pressure on the vitreous jelly humor that's putting pressure on the retina. This increased pressure can cause us to lose our peripheral vision first, start losing that peripheral vision, and can really narrow down our field of view. That's called glaucoma. So glaucoma is a disorder where there is an increased amount of pressure being put on the retina from an increased amount of pressure from that aqueous humor putting pressure on the front chamber, putting pressure on the back chamber, posterior chamber, and causing a loss of those photoreceptor cells, narrowing your field of view. Now there's a different disorder, and actually in developed countries, this is the most common cause in adults of you know, the most common cause of loss of sight. It's called macular degeneration. But in macular degeneration, due to a lack of nutrients to these photoreceptor cells that are for our highest visual acuity, you start to lose your sight from the center out. So it's different from glaucoma, losing sight from peripheral in. Macular degeneration, you've lost sight from the center going out. And again, both would be awful, you know, but that's the difference in those. Now, where the optic nerve, where all of these photoreceptor cells that are being innervated and action potentials generated, those messages are being sent to the optic nerve where it leaves the back of the eye. So there's no photoreceptor cells here, and that is what people refer to as their blind spot. And there are little things you can do, little fun things you can do to figure out where your blind spot is. But anyway, that's what's meant by a blind spot. Now, again, refractive properties of light. As light comes in and hits a clear object, it is going to be, when you think about it striking the lens or the cornea at a 90-degree angle, it's actually not bent, but it's bent because the cornea is curved. This cornea is curved. And again, as this refractive properties of the cornea are hitting this, light is hitting this cornea and it's moving through, it should be concentrated, refracted to be concentrated on the central fovea, the fovea centralis, the macular region. Now, if it is not being bent and concentrated to look like this, then that means that you have a problem with your sight. And we'll look at a couple of the most common names for those problems and what is actually occurring. So, depending on if you are looking at objects up close, so like a pen, looking at something up close and your eyes have to accommodate that, or looking at something far away, this lens can change shape. It can change shape. It's very malleable, this lens is, and as the lens changes shape, again, it's all to refract so that the concentration of those light waves are hitting at the central fovea region. So we can see some, distant and near sightedness type thing. I wanted to show you just the accommodation of this lens. So when you think about accommodation of the lens, so you're looking at distant vision. Distant vision here, you can see the lens is pretty much pulled out and thinned out. But near vision, the lens has to be, again, the lens has to be relaxed, and the lens is going to thicken here for near vision so that you can see. Maybe some of you know that there is something that happens as we age where you see people who are reading something, and as they're reading something, as they're aging, they're moving it further and further away. The reason that they're moving it further and further away is that as we age, a natural thing that happens is that the lens can't accommodate, it can't change as much as it needs to. So this is referred to as presbyopia. Presbyopia, which is just normal old age farsightedness. You hear about normal old age farsightedness where people are moving things away, and they need to get maybe some old Durham store glasses to help them with that. But that is called presbyopia. Now, when we think about myopia, which is what I am, nearsighted, the eyeball is actually in myopia. The eyeball is so elongated that what ends up happening is that as refraction is happening, this is in the normal before it's corrected, as light moves into the cornea and is refracted through the lens, it actually is hit, the place where it's being concentrated is still here in the vitreous humor. So the vitreous humor is just jelly, right? So it continues to be refracted, and now instead of being concentrated here, it would hit right here, and now it's kind of being spread out. So corrective lenses would correct it so that it again is concentrated on the central fovea or the macular region. And hyperopia, this is farsightedness. So farsightedness, then what is happening is as light moves in, again, it would require your eye to, it certainly can't move through these layers, but this is the imaginary plane that it would take for the light to be able to go to. But instead of being concentrated, you can see it's still spread out here. It's still spread out in the macular region. So what you have to do is corrective lenses, and the corrective lenses can again get this refraction to be where it needs to be in the central fovea. So these are some of the more common disorders. People sometimes have what is called astigmatism. Astigmatism is a misshapen cornea. Sometimes corneas can have almost little divots or curved where they shouldn't be curved. So that's what an astigmatism is, and they're different types. So instead of having this nice, normal, natural curve, it doesn't have that. So that's an astigmatism. Some people, the lens is clouded, it starts to cloud. Clouding of the lens is called cataracts. And if there's clouding of that lens, then the light gets refracted back. So depending on the degree of cloudiness, you may have really lost sight, but they can actually replace lenses of people with cataracts, do surgery to pull this lens out and replace it with the lens. So anyway, that's a cataract, a cloudy lens. Astigmatism is an irregular shaped cornea. Glaucoma is pressure from the aqueous humor. You're always producing aqueous humor and vitreous humor, and you're reabsorbing it too. And that has to stay balanced. If for some reason there's too much pressure, then that's going to put pressure on the retina, which causes a peripheral loss of vision that's progressive. So you have to stop that. So it's important to have eye exams, again, just to detect some of these things that may be so slow and happening that you're not picking up on them. So anyway, that's glaucoma. Macular degeneration means that at this central fovea macular region, that's where you are losing your sight. Presbyopia means that the lens can't thin and relax the way that it has, and that's normal with aging. That's why they call that, old age farsightedness, presbyopia. Then we have hyperopia, and also we have myopia as well. So hyperopia, farsightedness, and myopic. Being myopic means not nearsighted. Now, as far as that retina goes, there are a couple of different types of cells that we associate as photoreceptor cells. I love this scanning electron micrograph because you can see the two different types. There are cones, as you see here, and there are rods, as you see here. Now, you can see the different anatomy here. But what I want you to know, is that rods are the cells that are nervated when we don't have much light available. We really can't see in the dark, but typically in nature there's very few situations that it is total dark. Like if we were in a cave, it would be total dark, right? But even at night, usually there's maybe a moon or there's stars in a natural situation, stars or some sort of reflection, from a night sky, but we can see very little at night. We can see images, we can see whatever, and that's from our rod cells being innervated in low light situations. Cone cells are going to be innervated when there's plenty of light, so daylight situations, and in daylight situations where there's plenty of light, we can actually see color. Now, there are several different types of cone cells for color, and some people, through an inherited loss of, so 3 different types of cones. So through an inherited loss of not having a particular type of cone cell functioning, where they're said to be colorblind. This is a sex-linked disorder, so it is on the X. These are on the X chromosomes. And so we do know for color blindness, there is more males have color blindness than females. So this is a very common one, a test for red-green color blindness, where in these dots here, there are people who have red-green color blindness would not be able to make out this number 16 here. So there is a number 16 here. If you can't see that number 16 within these dots, then you have red-green color blindness. But there's multiple different types of color blindness, and again, that is a genetic lack of information from those particular cones. So The rest of these slides in your PowerPoint actually are going to be just pictures of looking at models here of the eardrum. So looking at eardrums, looking at the little auditory ossicles, the malleus, the incus, and the stapes, looking at dissections of a cow eye, the anatomy from your Anatomy and Physiology Revealed, some pictures looking at someone with cataracts, the lens being clouded. The pupil, remember, is not an object, it's a hole. So the pupil is going to dilate in low light situations and constrict down in high light situations to protect those photoreceptor cells from getting bombarded with too much light. And so you can see the different pictures here. I'm hoping, I really did not, I want to do this really quickly. I'm going to go to, I thought I had those included here, but I don't. I'm going to go to some images. I'm going to look this up just so you can see for macular degeneration, what happens in macular degeneration, so the symptoms, and look at some images of people who have. So in macular degeneration, in normal vision, you can see these, look at their little teeth, so sweet, noses, different noses, but you start losing your vision from the center out. You only have, and you don't even have this very much. This is very sad. Someone with macular, they've really lost a lot of their vision here. But I also want to show you glaucoma. Glaucoma is going to be a little bit different. You're going to be losing your vision from the, it's the peripheral vision. I don't know, I just looked up glaucoma, I thought I did. Glaucoma. Why does it keep doing that? That's so weird. Glaucoma, I was seeing if I could see a picture of someone, what they've lost. It's not showing it. But anyway, so in glaucoma it would be very different though, losing the peripheral vision. And so I hope that has been our lecture on the special senses. And I hope that you guys, I think that you guys probably got everything you need from that. Please remember to look at your deeper insights from this chapter and also the disorders tables from this particular chapter. And I will sign off now. Congratulations, you have completed the material for Anatomy and Physiology 1.